எப்ப அன்மியூட் ஆக மாட்டேங்குது.
The ICH people have not joined.
Ma'am, சொல்லுங்க ma'am.
ICH is not joined.
Ma'am, I called madam. She's trying. There's some issue.
Ma'am, we
She joined.
Hello.
Join பண்ணிட்டாங்க. மேடமும் join பண்ணிட்டாங்க. பாபதி மேடம்.
Okay.
Good afternoon, Dr. Varanthi.
Sir, good afternoon, sir. Welcome, sir. சனிக்கிழமை மத்தியானம்.
We can start off, I think.
Yes, ma'am. Okay, ma'am. You're starting on dot.
Yes, ma'am. There are 13 cases, I believe, so we'll start off early for that.
Okay, ma'am. Welcome back, all of you. And I'm most happy to welcome you all to the new year 2021, where we continue on our journey of continuous learnings. And it is indeed heartening to see our request for presenting cases, and I thank you for all the enthusiasm shown. And so we begin our first meeting of 2021. This is the 24th meeting. And may the spirit of Professor Tilakavati guide us this year. And knowing her, I'm sure her blessings are with us as we undertake this journey. And we can observe a minute of silence in her memory. Ma'am, with this, shall we go on? Shall we start the meeting with the first case?
Yes, ma'am. Yeah, we can start off.
So our first case is by Dr. Bharati from Srihar. By Dr.
Yes, ma'am. I'll start sharing my screen, ma'am.
Yeah.
Is my screen visible and audio clear, ma'am?
Yeah, everything is fine. You can go to slideshow mode and start off.
Yes, ma'am.
Padma, I
Yes,
think you
ma'am.
have to mute the other audience because there is some disturbance going on. Everybody should definitely mute. Otherwise, this disturbance is there.
Hey, இது join பண்ணலையா?
See,
City pathology meet.
see this. Somebody is loudly talking. They have to switch off their mic. Okay.
Okay, ma'am. Shall I start, ma'am?
Yeah, Dr. Bharati, you can start off.
Yeah. Good afternoon, all. So this is Dr. Bharati presenting from Sri Ramachandra Medical College. So today I have an interesting case. The patient is a 63 years old male who presented with right scrotal swelling for the last 6 months, and it was progressively increasing in size. And there was a vague pain on and off, not bothering so much, but he had complained some amount of pain, and no history of fever or any other constitutional symptoms, ruling out a possibility of infectious etiology. And there is no history of trauma too. So on examination, clinicians found that the lesion was about 8 centimeters and no warmth or tenderness noted. And it was soft in consistency, and the left other side scrotum was normal. And routine investigations were all done. His hemogram, everything for his age, it was normal. LFT, RFT, urine analysis, everything was normal. And tumor markers, I'll talk about it later. And he was ordered as a routine. They do a Doppler ultrasound for the scrotum for any testicular lesion. For this patient also, it was advised. And the radiology report stated that the right testicular parenchyma was homogeneous with a focal heteroechoic lesion. That is the term exactly they had given. A focal heteroechoic lesion showing intense internal vascularity, and also a complex multi-septated cystic lesion in the medial aspect of the right testis, which was likely to be an epididymal cyst, was the comment given for the second lesion. So they have stated 2 different lesions in the same testis. So with that, the tumor markers was also done because they wanted to rule out a malignancy in that patient, since there was an internal vascularity, that is increased vascularity noted in the smaller lesion. So right architectomy was done, and the gross specimen was received in the department. This is just before fixing just after cutting, post fixing, we were able to identify 2 lesions. One, the smaller lesion was fairly circumscribed, reddish in color, and the larger lesion was about, say, 6.5 centimeters in length. And you can very well appreciate the compressed testicular parenchyma and this epididymis, some amount you can appreciate here. The rest of the testicular parenchyma is not visualized. And after fixing, we are able to very well see this circumscribed lesion very well encapsulated in areas. And it seems to merge with this testicular parenchyma here. And this large lesion is also just away from the smaller lesion, and this also embedded in the interface of the testis and the epididymis. And the spermatic card was absolutely normal. And this is the one slide that I could get from the scanner view, where I could include all the 3 in one plane. This is actually the atrophic testicular parenchyma. You may not be able to see properly in this power, but please, this is a atrophic testicular parenchyma that was noted. And this was the smaller lesion that we identified, that is the reddish cherry red-like area that I showed in the gross. And this is the multiple cystic lesion that we noted grossly. So this is the one more area where to show there is a testicular atrophic parenchyma with a well encapsulated smaller lesion adjacent to it. And this is the bit given from that jelly-like area. This is a fresh tissue, which showed lesion which is having multiple vascular channels. A higher power view of the same to highlight there is a nice capillary size blood vessels. And this is the section given from the larger lesion. So they showed a cystically dilated spaces with some amount of eosinophilic material inside the lumen. This is another view of, it's another section where we could appreciate that there is a compressed epididymal tissue, and which is very close to the larger lesion that we were appreciating in the gross. And the rest of the parenchyma, he's a 63 years old, so it showed some amount of atrophic seminiferous tubules, age-related changes. So with that, I just wanted to bring this to the forum. It was really a testicular teaser for us. If anybody would like to ask further what it can be, or any differentials, morphological differentials if you have, we'll be happy to hear, if time permits, or I will just go on. One thing the question raises here is, what about the tumor markers? The testicular tumor markers were within normal limits. So with that, we had this, since we examined many vascular channels, so we went on to do a basic CD34 staining, and it was negative in those larger blood vessels, larger dilated spaces. And here again, I am able to see the endothelial cell is not stained by that CD34. And the smaller ones, it's highly highlighted by the CD34 stain, and it's very much similar looking hemangioma. And this is a hyper view of the same, highlighting beautifully the lined up CD34 positive endothelial cells. So again, I would like to bring it to the forum, any diagnosis at this stage. We also, it was a morphological diagnosis. The CD34 is just a contributory factor to our confirmation. So when we were looking into the literature, we were able to find out this diagnosis of a hemangiolymphangioma, which is a really rare entity. So I just would like to go on for the discussion. So it's a rare mixed vascular malformation. And as it has a combined, that is both blood vessels as well as lymphatics can be seen in these lesions. Physiologically, they are benign, but they have a propensity to invade the underlying tissue. So hence they may recur frequently. And according to the literature, the possible etiology may be a coexistence of both entities, that is the hemangiomatous lesion as well as the lymphangiomatous lesion. So they have some common pathogenesis, which is designated as anomalies of the lymphojugular sac due to any developmental anomaly in the embryos. So the common sites that were noted in the reported cases are head and neck, axilla, abdominal cavity, and extremities. But testicular lesions are extremely rare. That is what the literature says. So we wanted to present this case in this forum. So according to the International Society for the Study of Vascular Anomalies, they are broadly classifying this entity into two primary categories, namely the vasoproliferative or the vascular neoplasm, and the other one being the vascular malformation. So why is it called as a vasoproliferative or a vascular neoplasm? It's because of the rapid turnover of the endothelial cells. So they have observed that these endothelial cells rapidly proliferate, leading on to the neoplastic process. But the vascular malformation is basically a structural malformation rather than the proliferation of the endothelial cells as such. So in these cases, again, the proposed theory being the lymphatic channels, when they are developing, they may sequester somewhere in the developmental area. So they lost connection with the primary central lymphatic sacs. So in that case, because they are the mutated common stem cells from which these hematopoietic cells develop, so they have a propensity to form new channels either with the venules or with the surrounding capillaries. That is the reason behind, that's a proposed theory behind this malformations or the hemangiolymphangioma developmental anomaly. So this lymphatics can combine with the venules or the lymphatic channels can combine with the capillaries, and they form like a mass wherever the lymphatic tissue is going to be developed. And we know in the testis, it is that epididymal, and the interface between the testicular parenchyma and the epididymis is rich in this lymphatics. So they may have a propensity to develop there. That is the idea behind this developmental anomalies. And what they say is this hemangiomas or lymphangiomas by nature, they can regress spontaneously over the time. But in some patients, it may persist and suddenly they may pop up like a large lesion. So that is the reason even in an elderly, we can appreciate such lesions. Otherwise, if it is purely hemangioma or lymphangiomas in children, usually it regresses spontaneously. And another thing they say is vascular malformations, they may be harmless, but they may persist even for lifetime. And when we were reading the literature, we came across this entity called Klippel-Trenaunay-Weber syndrome, which is nothing but a congenital soft tissue anomalies, which has multiple hemangiomas, asymmetric limb hypertrophy, and arteriovenous fistulas. But our case is an isolated lesion, and it is extremely rare, and only few cases are reported in the literature, and it has a very good favorable prognosis. And we should always, as pathologists, should keep in our mind the differential diagnosis whenever we come across such new entity. It is being a benign on histology, we thought these are the common differentials, which is nothing but the same cavernous and capillary hemangiomas, pure component of hemangioma or pure lymphangiomas and adenomatoid tumor. And IHC would help to differentiate each one of it. Capillary and cavernous hemangiomas are positive for CD34 and CD31 will help. And lymphangiomas is D240, but we don't have that stain, so we couldn't do D240. But they say even some percentage of lymphoepithelium can also show this positivity for CD34, but otherwise it can be negative. Here in our case, it was negative. So we thought it is a combined hemangioma and lymphangioma. And adenomatoid tumor, we never thought of this because of these two lesions, which was positive for CD34. If it is negative, should have done a WT1 to confirm the paratesticular adenomatoid tumor. So that was an interesting case of hemangiolymphangioma, which was rarely encountered in the literature. So I would like to thank our professor, Dr. Sandhya Sundaram ma'am, Rajendran sir, for giving me this case to present in this forum, and Dr. Priyadarshini, who is also part of this case as a consultant, and Dr. Vishnu Priya and Ritika, my postgraduates, who helped me in taking pictures and collecting history. Thank you. Ma'am, shall I stop sharing, ma'am?
Yeah. That was a good presentation, Bharati.
Thank you, ma'am.
Any questions?
No questions, Valar. But these kind of vascular malformations and the so-called venous type of angioma, we come across quite often in the pediatric population.
Yes.
Soft tissue. And this kind of, lymphangiomas of the venous type, that's called a venous lymphangioma, we have seen quite a number. These kind of tumors are more common in children.
Yes.
And this is a rare entity in the adult. I do agree.
Thank you, Sita madam. Actually, right, most in pediatric age groups. But the interesting part is it had both the lymphangioma and the hemangioma.
Yeah, that is what. Sandhya, the same thing. Yeah, even in pediatric population, we do come across lymphangiomas, but with kind of a venous morphology,
Yes.
So when you do not have the eosinophilic secretions, or when you do not have the wall showing lymphoid aggregate, we cannot call it a lymphangioma type of a lesion, right? So in that case, we call it a venous lymphangioma. So
here it was
this case, very good case, and a very good photographs were excellent. Photograph
Thank you so much, madam.
Presentation was excellent.
She had taken the trouble to present the rare entity. And when we saw it also, I didn't know this terminology was there. Lymphangioma. Then I told Priyadarshini, Dr. Priyadarshini, to actually search it up. And then we found this terminology which combines both hemangioma and lymphangioma. Like you said, madam, lymphangioma with venous malformation is more common. But this kind of combined terminology we came across only when we searched.
Very good.
So thank you so much, madam, for that added comment. Thank you.
Okay, okay, ma'am. Thank you. Shall we go on to the second case from Mehta Hospital, ma'am? Madam, Sita Lakshmi, madam.
There is some feedback in your audio. I think you should have only one system.
I have only one system, ma'am.
I think some mobile is there and there is some feedback. Just take that.
You are able to see my presentation?
Yes, ma'am. Yes.
Are you able to see the slides?
Yes, ma'am. Everything is fine.
Okay.
Good afternoon, everyone. I am Dr. Impana from Mehta Hospital. I'll be presenting two cases. What makes me interesting is that we have a complete workup of both cases, and more importantly, both the patients are discharged. And the first is a case of a 6-year-old male who complained of pain while passing urine, dribbling of urine since 3 days, and history of pain abdomen since 1 day, and vomiting and loose stools. Clinically, a diagnosis of acute gastroenteritis with dehydration was made. His initial investigations showed CRP was negative, SGOT-PT normal, spot urine, creatinine, calcium and uric acid were also normal, but motion occult blood was positive and urine culture did not show any growth. CT scan showed that entire colonic loops were thickened and edematous with extensive surrounding pericolonic fat strandings, which suggested severe colitis. Also, mild to moderate free fluid was seen in the abdomen with severe cystitis. Echo was normal. Initial CBC values on the day of admission showed leukocytosis with a eosinophil count of 21% and absolute count was more than 5,000. But after 9th day of admission, his eosinophil count rose up to 64% with an absolute count of 20,000. Hence, a peripheral smear was requested and it showed severe eosinophilic leukocytosis and there was no immature cells. Further investigations was done. Ferritin LDH were normal. Immunoglobulin IgE was moderately elevated. Clostridium difficile toxin was negative. Urea creatinine were normal. And to rule out autoimmune etiology, anti-dsDNA and ANA ELISA were done, which was negative. As severe colitis was seen on the CT scan, colonic biopsy was done. We received 3 separate containers of cecum, ascending colon, and rectal biopsy. All the colonic features, all the biopsies showed similar features with fairly preserved glands, but the lamina propria showed inflammatory cell infiltrate with focal lymphoid follicle formation. And as you can see, many eosinophils were seen. Although there is no strict criteria for eosinophilic colitis, it is considered more than 20 per HiPA field is considered as eosinophilic colitis. Bone marrow aspirate was also done for this patient, where ME ratio was normal. Erythroid series showed normal maturation, and myeloid series, more than 60% were formed by these eosinophils. Another picture showing eosinophils and erythroid maturation. International Working Group on Eosinophilic Disorders have given various definitions for eosinophilic disorders. They define blood eosinophilia as more than 500 cells, whereas hypereosinophilia as more than 1,500 cells in blood on 2 examinations at an interval of more than 1 month. They define tissue hypereosinophilia as percentage of eosinophils more than 20% in bone marrow, or extensive tissue infiltration by eosinophils, or there is marked deposition of eosinophilic granules is found. Hypereosinophilic syndrome is defined as criteria for peripheral blood hypereosinophilia is fulfilled, and there is an organ damage which is attributable to the tissue hypereosinophilia, and other causes are excluded. So the new proposed definition, which is different from the old definition, is that they have removed the 6 months time criteria and they have included it as 2 occasions, and they have included tissue eosinophilia as also a criteria for hypereosinophilia. The other point of exclusion of secondary causes remains the same as old definition. Over the time, there are various classifications for hypereosinophilic syndrome. Initially, HES was given for patients with organ dysfunction, but then came into picture myeloproliferative HES with PDGFRA gene mutations. Then came into picture lymphocytic HES, which was mainly given for patients with dermatological conditions and they were treated by corticosteroids. ICOG has defined HES with various terminologies like undefined, familial, associated, and overlap. We have classified ours as complex type of undefined because there was organ dysfunction, but there is no immature cells which indicated myeloproliferative or a lymphocytic variant. This patient was treated with steroids and empiratively with antihelminthics, although there was no detectable parasite. So on discharge, that is after 15 days, his eosinophil count came down to 8 and with an absolute count of 600. So we made a final diagnosis of complex type of undefined hypereosinophilic syndrome. Going to second case, this is an 11-year-old girl who was referred from other hospital for fever and jaundice. She had high-grade fever for 3 days, yellowish discoloration of urine and giddiness. Also, she had breathlessness while climbing stairs. Development was normal and was immunized up to age. Her CBC values revealed hemoglobin was anemia. She had severe anemia with an RBC count of 0.7 million. MCV, MCH, and MCHC were abnormally elevated. Platelet was mildly reduced. So hence blood grouping was asked, seeing low hemoglobin. So forward grouping showed B positivity, but as you can see in the gel card, and also we confirmed this by test tube method, there was mild hemolysis in the A blood group, but this was also seen in the control. So we did reverse blood grouping, which confirmed B positivity, and direct Coombs test was strongly positive. When our blood consignment unit received for cross matching, the major cross matching was done and it was incompatible with B positive. So we advised O positive, which was also incompatible. And finally, O negative was also incompatible with 2+ reaction. Her LFT showed increased total bilirubin and indirect bilirubin. SGOT-PT was normal and alkaline phosphatase was mildly reduced. LDH was also mildly elevated, whereas blood urea, serum creatinine, ferritin, and PT-APTT were within normal range. Her peripheral smear showed extensive autoagglutination with many polychromatophils and few nucleated RBCs and some occasional spirocytes. Reticulocyte count was increased, and which was 33%. Bone marrow aspiration was done. It showed erythroid hyperplasia with megaloblastic changes and mild dyserythropoiesis in the form of binucleation and cytoplasmic bridging. Another picture showing megaloblastic maturation. So to rule out secondary causes, further investigations was done. Mycoplasma and lepto-IgM were negative. Dengue IgM was mildly positive, and EBV antibody to the viral capsid antigen was also mildly positive. Cold agglutinin qualitative test was asked, which showed both cold and warm antibodies. C3-C4 complement level was done. C4 level was reduced, and this decreased level is common in autoimmune conditions. Also, ANA was done and it was positive, and cardiolipin antibody IgM was also found to be positive. So traditionally, autoimmune hemolytic anemia is classified as warm, cold, or mixed based on the optimal temperature of reaction, whether it is 37 degree or 4 degree or both. Why is it important to differentiate is mainly because of the treatment purpose, where in warm type, mainly it responds to steroids, but in cold type, steroids should be used in an unacceptable dose. So hence steroids is not preferred and rituximab is preferred. So this patient, her course of admission, over the course of admission, her hemoglobin almost came back to normal, 8.2 gram, with a PCV of 24, and RBC count was 2 million. She was treated with IV immunoglobulins, oral steroids, and there was no blood transfusion because even O negative showed a 2+ reaction. So finally, our diagnosis is that of a warm and cold type of autoimmune hemolytic anemia, secondary to query infection, or the clinicians are suspecting whether it is an evolving SLE, which is because of the positive ANA and the cardiolipin positivity. Thank you.
I would like to just highlight and summarize whatever Impan for the benefit of the junior pathologist. See, these two cases are not so common. I won't call them uncommon, but yet they are common as far as the clinical approach is concerned. And one should be able to diagnose and treat them. You see, both were treatable conditions and both were very, very small children. One was a 5 to 6 year old boy, and another one was a 10-year-old girl. And the important point, anybody, see, children, it is very common to find eosinophilia. Very often we find our own kids, they present with running nose and things like that. And we do find a higher eosinophil count in the peripheral smear, and the parents get very much perturbed. But what is important from our point of view is to distinguish between 3 important conditions. One is eosinophilia, second is hypereosinophilic syndrome, and third is the leukemic pattern. As WHO puts it, you have 2 varieties of hypereosinophilia. One is a leukemic pattern in which, as she said, you have the myeloproliferative lymphocytic type, and then of course there are a lot of genetic mutations. And the other type is the hypersensitivity reaction, which you all know in the immune reactions. We talk about various reactions, and here of course the IgE is responsible for this hypersensitivity. So the important point of difference is to examine the peripheral smear for immature cells. It should be more than 2% if it is going to be a myeloproliferative group. And in the bone marrow also, it should be at least 20%. In the absence of these two, and a very high absolute eosinophil count, and of course, the tissue involvement, it has to be considered only as a benign form of a hypereosinophilic syndrome, and it was treatable. The patient went home very happily with almost a normal eosinophil count, and absolute eosinophil count, as far as the children are concerned, it can go up to 1,000. So anybody who is working in any of the pediatric attached hospital or department, whenever you come across an absolute eosinophil count of more than 1,500, alert the clinician and look for the underlying cause. That is a message that I want to convey as far as the first case is concerned. The second case, very easily it can be clinically diagnosed. Of course, the laboratory profile helped them a lot. You see, the problem we found was when we started grouping the blood because the request first says 4 gram hemoglobin, we want an urgent transfusion for this child. But we were unable to provide any blood group for this child. Then only we went in and told them that it could be an immune mediated mechanism, and then it started off the trigger. We did all the investigations, and remember, any child with anemia, marked anemia, fever, reticulocytosis, and indirect bilirubin raised, all this will and with the mild hemolysis and an ambiguous blood grouping, please think of an immunohemolytic anemias. The immunohemolytic anemias in children is very, very common because most of them come with a viral infection, and it is mainly the secondary type of autoimmune or immunohemolytic anemias, which is very, very treatable, and it provides a great relief to the parents as well as to the treating clinician. So this is another take-home message that I would like to convey. Thank you for giving us the opportunity to present these two cases.
Dr. Divya Priya, you can ask. I think she has a question, madam. Dr. Divya Priya.
Yeah, definitely.
Dr. Divya Priya, you can unmute and talk or message.
What is your question? Read the question.
She said to us. She's asking hypereosinophilic syndrome in old age.
Yeah, I know, I saw. Actually, to quote an example, my husband himself has a hypereosinophilia only. No, that is because of an underlying allergic laryngopharyngitis. So very often eosinophilia must be secondary to something else. See, both children and extremes of age group, they behave in a very similar way. So it is for us to work up and see whether there is any underlying etiology for the eosinophilia and treat the cause, then eosinophils will come down. Same thing happened with my husband, who is now 77, and we treated him for hypereosinophilia, and his now eosinophil count is only 7%. So what I'm trying to say is you'll have to find out, work up, find out the underlying etiology and treat the cause.
Okay.
I'm happy Dr. Edilarasi has joined. She is the pediatrician who treated these two cases. Edil, please unmute, and I would like your comments in this for the benefit of all the pathologists. I'm extremely happy that you have joined.
Ma'am, I think it's almost like very concise that Impana has highlighted everything. We've had about 6 or 7 so far cases of hypereosinophilic syndrome. The only problem that occurs is when the eosinophil count we categorize as mild, moderate, severe. So the severe ones sometimes come with cardiac failure because of myocardial infiltration. This child had a GI infiltration. We had a girl we diagnosed, and after about we started her on steroids, but it took little time to come down. And about on the 3rd week in the night, she came with severe cardiac failure. She had myocardial deposits, in eosinophilic myocarditis, which can be life-threatening in children. That is one thing and these take a little longer time. So we'll have to monitor them periodically. We've taken 6 months to 1 year. We have given steroids to get it under control. And some children present with extensive eczematous skin lesions, which can be very frustrating for the child because it is very itchy. That is about the first case. And the second case, yes, this immune hemolytic anemia is always a therapeutic challenge because the first 3 days when they present with sometimes HB of 2 and 3 and a 30% with ongoing hemolysis. We are not able to give blood. Managing the anxiety of the parents and keeping the child not on transfusion is really a clinical challenge for the first 2 days. And this child, though this is another case where both BCG and ICG was positive, both mom and cold antibody, which was even more challenging. This child, EBV also came positive. So we had something more than this, 1 point triggering off, and this girl was 8-year-old. So any adolescent, 8 to 10-year-old girl child presents with immunohemolytic anemia, we always want to rule out connective tissue. This could be a start off of a SLE. That's how most of our SLEs start off, either with pancytopenias or with hemolytic anemia and thrombocytopenia. So those 3 days were really challenging. Thanks to the lab, like they kept backing us up with all the reports, and fortunately with IV MPS on the 3rd day, the HB picked up to 7 and we could send the child home without transfusion with steroids. But I think it's going to be a challenge because it is not going to be a 1 day, 2 day affair. This is going to be a long-term chronic treatment for this child.
Okay, thank you, Adil, for
Thank
the
you, ma'am.
Thank you, very nice. So that is mainly for the practicing pathologists and the people who are attached to pediatric institutions and people who are dealing with hematology. Just to create an awareness, we thought we will definitely present these 2 cases. Thank you, Valar, and thank you, Padma, for giving us the opportunity.
Ma'am, thank you,
It
ma'am.
was really wonderful. And the interaction was really good. It was really nice.
Thank you.
We can go on to the next case.
Yes, ma'am. Dr. Gauri Priya from Rela Institute, ma'am. Dr. Gauri Priya?
Yeah, they are there.
Yeah, you can unmute and start.
Have to share your content. Can you go to slideshow mode?
Yeah. Good afternoon, ma'am. Can you see my screen?
Audible? Yeah. You are audible. Your screen is visible.
Good afternoon. I'm Dr. Gauri from Rela Institute. Today I'm going to present a simple but rare case which we see in pathology practice. A rare swelling in the occipital region. A 42-year-old male patient presented with a swelling in the occipital region which was slowly progressing in size over the past 3 years. The present size was 10 into 6 into 5 centimeter. The patient gives a vague history of similar complaints 10 years back. At that time, a biopsy was done and it was reported as acne vulgaris. So this is the clinical picture. There was a large, fleshy, skin-covered swelling with a loss of hair over the swelling. And multiple hair shafts were seen projecting from the periphery of the swelling. We received the excision specimen. This is the cut surface of the specimen. There was a big swelling mainly centered in the dermis of the skin, and multiple hair shafts were seen entrapped in the dermis. The swelling had a whitish and myxoid cut surface. These are sections from the swelling composed of a slightly flattened epidermis and a lesion in the dermis composed of collagen bundles and fibroblasts. This is the closer view of the collagen bundles, which are haphazardly arranged. And mild perivascular inflammatory infiltrate was also seen. It is here. Some of the foci showed more number of plasma cells also. So from this picture, what is the impression from the gross and microscopy? Can anyone contribute? Can I continue with the presentation? Yeah.
Yes, doctor. Yeah, you can go.
So basically, it was a lesion composed of collagen bundles and fibroblasts.
and we couldn't categorize it into any tumor, but we also had taken some bits from the periphery of the lesion where you could see the hair shafts projecting from the skin surface. So this is the interface between the lesion over here, and this is the periphery of the lesion. So at closer view, you can see that there is intense perifollicular inflammation with destruction of parts of the hair follicles. Again, intense perifollicular inflammation and dense dermal inflammation. It was composed of predominantly polymorphs. Again, here there is destruction of the hair follicle. Here there are micro abscesses which are actually replacing the hair shafts. Deep inside, we could see multiple fragmented hair shafts surrounded by foreign body giant cell reaction and polymorphs. And this is polytrichia, wherein you can see multiple hair shafts within same hair follicle. Again, you can see fragmented hair shafts surrounded by microabscesses and foreign body giant cell reaction. Here, you can see some extruded hair fragments from highly inflamed hair follicles. So our diagnosis was acne
The person you are speaking with has put your call.
It was first described by Kaposi in 1869 as dermatitis papillaris capillite. Clinically, it was described as pinhead-sized, at first isolated, later confluent papules which tend to coalesce to form keloid-like protuberant pale or reddish plaques. It's actually a misnomer. The lesion is not related to acne, and neither is it characterized by keloid-like proliferation. It is basically a folliculitis and perifolliculitis, which eventually leads on to dense inflammation and scarring. Mostly it happens in post-pubertal men, black men, and the most common site is nape of neck or occiput. The pathogenesis is really unknown. They consider that coarse curly hair in the skin causes chronic inflammation. So the better term is folliculitis keloidalis nuchae. Microscopy is characterized by follicular and perifollicular inflammation. Hair follicles are disrupted and broken hair fragments are surrounded by granulomatous, that is foreign body granulomatous inflammation. There is dense dermal fibrosis and scar. There is polytrichia, and there may be absence of sebaceous glands. Just for completion's sake, these are the other types of scarring alopecias classified according to the predominant type of inflammatory cells present in the lesion. This is not some fancy case involving novel diagnostic modalities, but I could be able to read some classic journals which were published in 1979, well before I was born. The clinician, the plastic surgeon, describes this lesion as the periphery, the advancing edge of the lesion resembles trees being engulfed by a moving sand dune, which we could appreciate here. Apart from the big scarring lesion, we could find that there are hair follicles which appear to be engulfed by this moving sand dune of inflammation and fibrosis. Again, that is seen very well in the gross picture as well. So the same was recapitulated in the microscopy. Here is the dense fibrosis and this perifollicular inflammation literally engulfing and destroying the hair follicles. So first described in 1869 with a nice description from 1979. I really had a feeling of reading a classic rather than having to present some novel case. Thank you. Hello? Am I connected still?
That was really good.
Can we have the next presentation also, and then we can go on for discussion, ma'am?
Yeah.
Okay. I had something to say. Anyway, I'll keep it at the end.
Yes,
No,
ma'am.
ma'am, if you want it,
After this,
You want me to talk now?
yes, ma'am, no issue.
Hello.
Sarah Paul madam is still there, no?
Hello, ma'am.
Remember, Sarah Paul madam is still there, right? Ma'am, you please unmute your phone because
Hello.
we reported same case when we were all in KJ. I don't know whether she remembers. Now this is given in liver also. This is the classical, that name is a keloid, and then nuchal is the back area of the neck which we present. And inadvertently, I think Gauri has revealed her age, saying that she was not even born when the first article was published. Anyway, Gauri, that was a nice case, and we have seen that it is a kind of a chronic, something like a psychosis barbe, where, when, it comes usually in the dadi affected area of the face, and this is something like a chronic deep folliculitis. Okay. Infected, and we have this kind of a problem. Very nice, Gauri. It is good that now we are having a non-neoplastic type of lesions in our discussions. I'm very happy.
Thank you, ma'am. Thank you. Thank you.
Dr. Asma can continue. Dr. Asma?
Yes, ma'am. I'm here, ma'am. I'm sharing my slide.
Yeah, take it.
Good afternoon, everyone.
Screen that, Asma. Screen
Am
is
I
not
audible?
seen. You're audible. Your screen is not seen. Not seen.
It is hard. When did you buy it? Eppo. Eppo kone? Where? How did you hear this noise?
Now is it audible?
Yeah, it is seen, but go to slideshow mode.
Slideshow, yes. Hello, good afternoon, everyone. I'm Dr. Asma, working as consultant hematopathologist in Rela Institute and Medical Center. So I'll be presenting a case relating to hemat here. So we had this patient who was a 64-year-old lady with, she had presented to the hospital on 12th of October 2020 with normal CBC parameters. At that point of time, she was admitted for COVID. And after that, she was discharged with no other issues with her hemogram or any other problem related to hematological parameters. So this patient was seen in OPD again on 5th of February with a history of myalgia and breathlessness. Again, COVID RT-PCR was done. So it was negative, and patient had a CBC where hemoglobin was on the lower side. You can see the comparison. Her hemoglobin had dropped to 8.6 grams. TLC was very high, hyperleukocytosis more than 2 lakhs. Platelets also had dropped down to 26,000. Coagulation parameters were within normal limit. PT, APTT were done, which were within normal limit in view of the high count. So I had shared these images on the group also. So any guesses from the images, if anyone can contribute? Morphological diagnosis from this. So if there are no inputs, then this patient had this uniform looking blast, which had some of them had that hand mirror appearance also. There is shift to left component, some myelocyte, metamyelocyte, and the other polymorphs, normal white blood cell lineages were suppressed. So these abnormal cells had a very high NC ratio. The nuclei was cleaved and convoluted in some places, very condensed nuclear chromatin with inconspicuous nucleoli. No OR rods were seen. So we went ahead with the cytometry on the same day because the patient had very high count and they needed the diagnosis to start the treatment for this patient. She was becoming sick. So as we can see, I will take you through the plots. So the first plot is this is the singlets plot where we are trying to exclude the double events. The next plot is CD45 versus side scatter. It can be taken the other way around, which is done by many other flow cytometrists also. You can take side scatter along the y-axis and CD45 along the x-axis. So here you can see CD45 bright lymphocytes are highlighted in light blue, and your progen, that is the immature population, is the one which is comprising 84.76% of the total cells that we have gated. Now coming to the next plot where I am trying to show you the phenotype of this progenitor population, you can see that the red population is the CD19 positive. The entire red population is CD34 negative. So the immature marker here is negative, whereas the same CD34 is positive in one subset. And the same subset you can see in the CD45, it has a heterogeneous positivity for 45 when compared to the red population. The red population is good CD45 positivity, if you ask me like that, like comparison wise. And the same blue subset, which is CD34, and there is another subset you can see in the same box I have highlighted here, which is CD19 negative and CD34 negativity. So I'm just trying to highlight the heterogeneity of the tumor here, which is very important. I will come to that point why it is important. So the next plot, you can see that the CD20 is negative. CD34, again, it is the subset which is positive. Then again, CD34 versus CD38. So the red population, which was CD19 positive, shows CD38 expression, whereas the blue population, again, the same subset, which is 19 negative, is again CD34 and 38 negativity. The next plot is the one which might give you a clue that there is no expression of CD10. So when you are using CD10 incorporated with these tandem dyes, the tandem dyes like PC7, where the PE is incorporated with cyanine 7. So that there is these tandem dyes will always give you some non-specific staining. You can see the trailing here. So that's why I have put here a density plot to show you that the CD10 is actually negative. If you put a quadrant and go for CD10 positivity, it may appear dim. So here you have to make a judgment based on, you know, the contour and density and the other parameters, keeping in mind that what type of dye you are using in flow cytometry. So that is the point of highlighting it here. So CD10 is also negative. So it is a basically CD10 negative blast population, which is negative in both the red and the blue population. Again, here I'm trying to show you the heterogeneity with 38 and 45. You can see how the red population is behaving and how the blue population is behaving. Same thing with CD58 and 34. Again, 58 is nicely expressed in the red subset, whereas the blue subset of the blue blast is showing 58, whereas the other one is negative for 58. Why so much importance to the heterogeneity? Again, I'll come towards the end after concluding my diagnosis. The next tube, which is the myeloid tube here, shows negativity for CD117. It was negative for CD13 and it was negative for CD33. Again, CD33 is on PC 5.5, which is a tandem dye. So these tandem dye, when they break down during the processing, they can give you some non-specific positivity. Another main marker which is giving you a clue here is CD15, which is incorporated with FIT-C. So CD15 is positive here. The positivity is heterogeneous. It's not a uniform positivity or a homogeneous positivity. The 15 shows a heterogeneous positivity on flow. The T cell markers were all negative. The cytoplasmic tube CD79 alpha is positive, and CD3, that is the cytoplasmic CD3, is negative, and MPU is also negative. So the lineage marker which is going in favor of the diagnosis here is 79 alpha, in spite of the heterogeneity the tumor showed you in the first tube. One more thing which is positive here is CD11B. So CD11B, again, one subset is positive and another subset shows clear-cut negativity. Impression given was a B cell precursor acute lymphoblastic leukemia in view of the CD19 positivity, CD79 positivity. So WHO has given you the guidelines to how to label a lineage when it comes to a B lineage or a T lineage. So B lineage, you can have a good CD19 with other CD10 or 79 alpha or 22 weaker. That is acceptable. So here the CD19 was good, and CD79 alpha is the additional marker, which again gives you a diagnosis about the gives a clue towards the lineage. So it's a clear-cut B cell precursor acute lymphoblastic leukemia. So the report was given, a descriptive report, where I have explained the first subset, which is the predominant subset, showing heterogeneous 45, 19, 38. The markers are well expressed. But there is a subset which is a very significant percentage, that is 31% of all the viable cells, which expressed heterogeneous 45, dim 15, 11B was also dim to negative, and it was positive for 79 alpha. But the point to be highlighted here is that particular subset was negative for 19, 20, 10, 38, and 58. So when you are, why this is important here is, when you are going to get this sample on follow-up on MRD, you cannot put the gate on CD19 positive cells or CD38 positive cells, which is our gating strategy in BMRD study. That is how all of us gate. The starting gate is on CD19 positive B cells and the CD38 positive mononuclear cells. So here, since this particular subset, which was approximately 30% of the tumor cells, was negative, clear-cut negative for 19 and 38, and if you are going to follow the regular BMRD gating strategy, you are going to miss the leukemic blast in the MRD sample. So that is the importance of highlighting this case. The leukemia-associated immunophenotype has to be clearly highlighted. It's not just one subset here, it's another subset also which contributed to the tumor heterogeneity. So overall features were consistent with the B-cell precursor acute lymphoblastic leukemia. We advise a cytogenetic evaluation because she is an adult. We advise Philadelphia chromosome. In view of the immunophenotype, MLL was the guess made, CD10 negativity and CD15 heterogeneity. So it was outsourced. So the fish for MLL, you can see it is positive. So the name for MLL has been recently changed to KMT2A gene rearrangement. So it was positive for rearrangement of the KMT2 gene, and it was negative for the ETB6 RUNX1 and BCR-ABL1 fusion genes. So again, I'm trying to highlight the leukemia associated phenotype. The impression has to incorporate these details in the diagnosis. When you're giving the diagnosis of BALL, you have to describe how the tumor is behaving, and BALL is one entity which has a heterogeneous expression, and how it is deviating from normal antigen expression. Normal means when you are going to get a bone marrow on follow-up, you may have hematogones there. So one must be aware of the normal antigen expression in the hematogones to look at how your leukemic cells are deviating from the normal antigen expression. And here you can see that the tumor also had myeloid markers. Those were the CD15 and CD11B. So there were cross-lineage antigen expression, but for a BMRD, it is not really going to make a difference whether you have CD15 and CD11B in your BMRD tube. You can do with your routine B tube to go and conclude whether your BMRD has come out positive or negative in such a case. Thank you. Any questions? I would be happy to answer.
BCR-ABL was negative, doctor?
Yes, ma'am. BCR-ABL we had advised because she is an adult. It was negative. She was positive for MLL as we had guessed it because of the CD10 negativity, high count, and CD15 expression. So all three were actually favoring MLL gene rearrangement, and it was positive for that, ma'am. The KMT2A fusion was positive. And as we all know that it has a dismal prognosis when it comes to, it is an infantile leukemia gene. So as the name says, the older name is MLL, mixed leukemia gene it is. So it can show such patterns.
That's a nice case. Thank you. Thanks for sharing.
Thank you, ma'am.
So if we have no question, yeah, ma'am. Then we'll go on to the next case, Professor Papati from ICH, ma'am. Papati, madam.
Yeah, she's nice. I have made her co-host. She's come in ICH, this thing.
Illa madam, Banu Shri, Banu Rekha, I just saw that name. Banu Rekha.
I didn't, Banu Kirtana.
Banu Kirtana.
I haven't made her co-host. Okay. If madam is not ready, next case, because we will not waste time.
Dr. Shweta from Apollo.
Yeah, ma'am.
Yeah, please start sharing your screen.
ICH, I think they've started. They unmute me. I think that Shweta can wait. ICH, she started. Go to slideshow mode.
Ma'am?
ICH, I think they have come. She
Yes,
has to unmute and. ICH,
hello.
you have to unmute.
Yes,
Unmute
ma'am. Yes, ma'am.
Yeah.
Go
Welcome,
to
ma'am.
slideshow mode.
You can start, ma'am.
Good afternoon. First of all,
Slideshow
I thank
Go to
Dr. Badma and
slideshow mode.
Vala. Slideshow mode. Good afternoon, everybody. Today we are going to present a case of a 4 years old male child presented with hematuria and left hypochondric mass. Ultrasound and CT scan shows a left renal mass measuring 10 into 8 into 6 centimeter, suggestive of Wilks tumor. So left nephroureterectomy was done, and we have received the specimen measuring 10 into 6 into 4 centimeter, and external surface congested, bosselated with intact capsule. And cut surface shows the whole renal tissue is replaced by homogeneous whitish tumor, fleshy tumor, with the one foci of thin rim of renal parenchyma is seen, with multiple small cystic phases are seen, with foci of necrosis. The section from the tumor area shows round oval to spindle shaped cells with stand to clear cytoplasm. They are embedded in a myxoid matrix, and they are arranged in parts, trabeculae, and in sheets, and some clear cells. And sections from the cystic area shows the multiple cystic spaces lined by flattened cuboidal cells, and occasional foci shows a hormonal pattern. And that shows pelvic calcium system is infiltrated by the tumor, and perivascular tumor infiltration seen, and focal perineural invasion also seen, and ureter is free of tumor infiltration. So our HP impression initially was a clear cell sarcoma of kidney, and because of these cystic changes and close mimic for CSK is our myxoid variant of synovial sarcoma. So we put it in the second differential diagnosis. So then we went for immunohistochemistry studies. So Vimentin that shows diffuse positive, CD99 diffuse strong membranous positivity, and diffuse strong nuclear positivity. Cyclin D1 here, there's only the scattered. Then we put other markers. EMA in the cystic glands positive, BCL2 again it's a few scattered positivity only, and BCAR positive. Other negative markers, WT1 negative and beta-catenin negative, CD45 negative. So with this positive markers, we come to the conclusion that BCAR related family of pediatric renal neoplasm. Because our October city path meet, I have presented a case of synovial sarcoma with a typical translocation. So we thought of rule out the renal synovial sarcoma, because the BCAR positivity is seen in both this CCSK and the synovial sarcoma. So we did the genetic study that shows, interestingly, the negative for SIT translocation. So then, so when we, so what are the other possibilities? CSK. So in CSK, so what are genetic other genetic studies are? 90% of the CCSK is associated with BCAR ITD translocation, and YW 12% with a YWHAE NUT M2B fusion. And another thing is BCAR CCNB3 fusion renal tumor. So BCAR alteration family of neoplasm, so more likely to be CD99 and TLE positive CCSK. So coming to the discussion, what are the BCAR alteration family of neoplasm? CCSK, BCAR, CCNB3 sarcoma of kidney and bones and soft tissue, undifferentiated round cell sarcoma, primitive myxoid mesenchymal tumor of infancy. But this one, our undifferentiated round cell sarcoma, primitive myxoid mesenchymal tumor of infancy, that shows the negativity for TLE. But CCSK and BCAR CCNB3 sarcomas, that shows positivity for TLE. And our case also shows CD99 positivity. So coming to the genetics, when you understand the genetics, only we can classify subtype that CCSK. So majority of more than 90% of the CCSK have internal tandem duplications of the BCAR gene. So whereas minority they have YWHAE, NUT-M2 or YWHAE FAM22 gene fusion. Another third category that comprises either CCSK with double negativity for BCAR ITD, YWHAE and NAT-M2 and YWHAE FAM22 fusion. So this is a very nice classification. So we should compare the typical CCSK and this CCNB3 renal fusion and our synovial sarcoma. So the third one is in the soft tissue sarcoma, BCAR CCNB3 bone soft tissue sarcoma. So we can rule out that thing. So the three, in the column, the three things are important: typical CCSK, BCAR CCNB3 renal sarcoma, and renal synovial sarcoma. So coming to the age, here the typical CCSK 3 years, the mean age is 3 years. For the fusion gene, 11.5 years, and synovial sarcoma in the adult. But we have reported cases in pediatric age group also. So in morphology, coming to the morphology, typical CCSK, as we all know, this round spindle cell separated by a branching capillary vascular, typical characteristic chicken white, this arborizing pattern is seen, and then myxoid stroma and numerous variant pattern. Why this pattern? Some of the transfusion, especially the YWHAE NAT M2-2B fusion, that is associated with the epithelioid pattern. And the BCAR CCNB3 renal sarcoma, here also cellular spindle cell sarcoma associated with entrapped dilated renal tubules. So in our case also we have seen the entrapped dilated renal tubules. The same morphology only in renal synovial sarcoma too. Then in genetics, in typical CCSK, BCAR IT 90% of the cases, and this YWHAE net M2B E fusion less than 10%. In synovial sarcoma, SS18 SS fusion. So this SS18 SS fusion shows a negative. So we have ruled out this renal stenosis is between typical CCSK and BCAR CCNB3 renal sarcoma. So these markers, these ISC markers, this TLE1 80% positive in CCSK and positive in synovial sarcoma, as we know, and cyclin D1 positive and BCAR positive. So BCAR is the most the latest the journal shows that BCAR is the most sensitive and specific for the typical CCSK for renal synovial sarcoma. Sorry, clear cell sarcoma. So that is why these BCAR positive tumors, we have to differentiate whether it is a 50% of the BCAR positive shown in synovial sarcoma also. So the TLE positive, cyclin D1 60% positive, and 50% of BCAR positive seen in synovial sarcoma. The genetic study is very, very important. With the genetic study only, we can rule out renal synovial sarcoma. So coming to the typical, whether it's a typical CCSK or BCAR CCNB3 fusion gene, so again that need the genetic study. Why it's not there? So our take home message: CCSK with double positivity for CD99 and TLE1, and it's very difficult to discriminate the CCSK from myxoid variant of synovial sarcoma only based on histopathological examination and immunophenotype alone. Most of the time, initially we thought with the ISC, we can easily differentiate the synovial sarcoma and CCSK. But again, we have problem with the ISC because the markers, they are positive in CCSK and synovial sarcoma. So that is why the genetic analysis for SYT gene rearrangement that required to reach a definite diagnosis. And our case emphasized the role of genetic testing in non-synovial sarcoma tumors with TLE positivity as a more specific method of diagnosis. And BCAR mutation again is essential for subclassifying non-synovial sarcoma tumors. Thank you. Thank you, madam. Any questions?
It was really good, detailed discussion about the molecular pathogenesis. It was really good, Dr. Patil.
Thank you so much.
That was an extensive presentation, ma'am. Any questions?
Any questions?
No, I don't find any questions being put in the chat box. I think we can go ahead. If there are any questions, people can. If you are there till the end, people, if they are asking, we can address it.
Okay, thank you.
We can go ahead with the next case.
Thank you, Madam Papati, madam.
Thank
and
you.
we'll go on to Dr. Shweta
You can
Lakshmi.
stop sharing, Dr. Papati. You have to stop sharing.
Anything.
Shweta, you can start.
Am I audible, ma'am?
Yeah, you are audible. You have to go to slideshow mode and start listening.
Sure, ma'am. First, at the outset, I thank the organizers for giving me the opportunity. I'm a consultant, Dr. Sweta, working in Apollo Cancer Center, Tenampet. This case is of a 43-year-old woman who presented with pain and swelling in the right side of the face. Followed by imaging showed a right-sided mass extending to the right masticator and infratemporal fossa. So the differential diagnoses were both neoplastic and non-neoplastic. Non-neoplastic was tuberculosis versus fungal infection. Also, a malignancy diagnosis was also rendered. So on examination, there was an ulcer in the right retromolar region, which was extending to the paramaxillary region, upper pole of right tonsil, and the base of uvula. Complete blood examination, except for anemia, there was no other abnormality. So she underwent a FES procedure in her hometown. The patient was actually from Northeast, where it was reported as granulation tissue with candida colonization. And for the further workup, FNAC was from the swelling was done elsewhere, where hematopoietic and a non-hematopoietic differentials were given. And here the patient came for FNAC of both the lesion and the cervical lymph nodes. These are the slides from the FNAC of the lesion, which is moderately cellular smears, showing these kind of single cells, some mononucleated, some binucleated cells. On high PAR, these cells had abundant cytoplasm with somewhat like a grayish cytoplasm, giving a squamoid appearance, though the cells were arranged in sheets. Some had binucleation. Yeah, this is a high PAR view of another cell which is having a lobulated nuclei with abundant cytoplasm, which is grayish, as we see in squamous tumors. So we were not really sure what the diagnosis was, whether we are dealing with a carcinoma or a lymphoma or a sarcoma. So we gave a poorly differentiated malignant tumor and suggested for a biopsy for further workup. The lymph node showed reactive hyperplastic change. So this is a biopsy from the site of that maxillary swelling, which is showing a blue cell tumor and this background of extensive necrosis. So a high PAR view, as we see, these are the tumor cells which are present in sheets and single cells with lot of destruction of the blood vessels. The outlines of the blood vessels are seen here, and there's amidst lots of necrosis. So again, we had similar differentials, whether it's a carcinoma or a lymphoma or a sarcoma. So we call it as poorly differentiated malignant tumor and ask for immunohistochemistry. So again, when we had a closer look, there was some kind of these binucleated cells with very, very prominent nucleoli resembling those of RS-like or RS-mimicking cells. But Hodgkin lymphoma in a non-nodal site with this kind of presentation was a little unusual and with this kind of background. So again, this to show the frequent mitosis and some cells with multinucleation. There were some cells having abundant cytoplasm, somewhat like a clear cytoplasm. So we asked for immunohistochemistry, where the tumor cells were negative for pan-cytokeratin and diffuse positive for vimentin. So it's a mesenchymal tumor. For further differentiation, the other markers were put in, like EMA and LCA. LCA showed diffuse positivity. So again, whether it's a Hodgkin lymphoma or a non-Hodgkin lymphoma, since extranodal involvement and those kind of binucleation raised the possibility of Hodgkin lymphoma. But even though LCA was showed diffuse positivity, Hodgkin lymphoma was also kept as a differential. So the other markers for delineation, CD3 and CD20. CD3 was diffuse positivity and CD20 is negative. So it's a T cell lymphoma. And the other T markers, CD4 was positive and CD8 was negative. There was loss of expression of CD5 and CD2 and CD7 showed positivity. And CD30, though not all cells were positive, there are a subset of tumor cells which showed membranous positivity. As you can see in the picture, there are it's a mixed pattern. There are some cells which are negative and some cells which are positive. So as of now, a T cell non-Hodgkin lymphoma, which the differentials included anaplastic large cell lymphoma, peripheral T cell lymphoma NOS, or extranodal NK T cell lymphoma. So to subcategorize, we went ahead with ALK, which was completely negative. So even though ALK was negative, ALK negative anaplastic large cell lymphoma could still be a differential. So the other markers, if, when CD30, it was like a mixed pattern. Not all cells were showed diffuse and strong positivity. There were a subset of tumor cells which were still negative for CD30. So, but in ALK negative ALCL, as we all know, CD30 should be diffuse positive. So the other two differentials were PTCL NOS and extranodal NK T cell lymphoma. So we did CD56, where majority of the tumor cells were positive. Granzyme, which was also positive. And Eberish is the marker which was very, very helpful. Eberish is in situ hybridization for EBV encoded RNA, which was diffuse positivity. So this blue color is all the positive cells. This is a high par view showing EBER positivity. So that ruled out PTCL. So the diagnosis is extranodal NK T cell lymphoma nasal type. Even though PTCL and extranodal NK T cell lymphoma can have a similar morphology, the diagnosis is based on CD56 and Eberish. When Eberish is negative, this diagnosis of extranodal NK T cell lymphoma nasal type should be given with caution, because nearly 100% of these tumors are associated with EBER. And PTCL NOS was one of the differential. When in the presence of CD56 and diffuse Eberish positivity, PTCL NOS is unlikely. So this case was presented mostly for its diagnostic challenge, because as you saw in the FNAC, it was problematic. There were cells with abundant cytoplasm, somewhat grayish cytoplasm, and when the clinical picture was more in favor of a carcinoma, and when the cytology was looking like squamoid cells, so it's always better to ask for a biopsy and go ahead with immunohistochemistry, where IHC in such kind of cases will be definitely helpful. So a few points of extranodal NK T cell lymphoma nasal type. Everything is given in the book. I just want to tell about few points. Mnemonic was 4 A's. It's very aggressive tumor, predominantly extranodal involvement, shows angiotropism with angiodestruction and necrosis, and 100%, nearly 100% of cases is associated with Epstein-Barr virus. It's a rare tumor, accounting for 0.2% of non-Hodgkin lymphoma. Nasal presentation is very classical. Apart from the nasal presentation, it can involve the nasopharynx, paranasal sinuses, orbit, etc. Ulceration of the mucosa with diffuse infiltration of lymphoid cells, which could be small to large size, is characteristic. And as I said, EBV is present in all the cases, and diagnosis is questionable if EBV is not detected. Now, for detection of EBV, we have immunohistochemistry by antibody LMP1, which is positive only in latency type 2. Whereas in latency type 1, LMP is negative, whereas Eberish will be helpful when Eberish is positive. So these tumors are associated with JAK and STAT activation, where 33% is positive for JAK3 and 33% for STAT3 mutation. I acknowledge the entire team of Apollo Hospital Pathology Department team and the organizers of City Pathology team and the attendees for their patient listening. We'd be happy to take any questions. Thank you.
That
Any
was a very good
questions, please?
workup, and didn't find any questions in the chat box.
Ma'am, then can we go on to the next case?
Yeah, that was a really wonderful presentation, Dr. Sweta.
So thank you, Shweta. Thank you, Shweta, for the good presentation. And we'll go on to Dr. Varsha.
You have to unmute Dr. Shweta. Dr. Varsha, you have to unmute.
Can you hear me?
You're not audible.
You can go to the
Now
first
you're
slide.
Start from the first line. There is a little bit of disturbance in your voice. Can you use a headphone?
Yes, ma'am. Just.
Yeah, you can start up.
Can you hear me now, ma'am?
Yeah, yes.
Okay. Today's case is a 39-year female who presented with nasal blockade. On examination, the left nasal cavity showed a friable growth measuring 3.5 into 2.5 centimeters, and there was no other significant lymphadenopathy. This growth was operated and sent for HPE. So on HND section, we saw respiratory mucosa with a diffuse infiltrate, which was distorting the mucosa, and along with squamous metaplasia. And it was infiltrated by small to medium-sized cells with extensive areas of necrosis. There were foci of florid pseudoepitheliomatous hyperplasia of squamous epithelium. There was also neural invasion and fibrinoid vessels, as you can see here. So the cells were small to medium sized with irregular nuclear membrane, a few cells showing prominent nucleoli, and moderate amount of pale eosinophilic cytoplasm. Frequent mitosis was noted, including atypical mitosis. So on immunohistochemistry, we did a CK5/6 and CK7, both of which were negative in the tumor cells, and showed positivity in squamous epithelium and respiratory mucosa respectively. CD45 was diffusely positive, which then we thought of a lymphoproliferative disorder. CD3 was positive in the tumor cells diffusely, whereas CD20 was negative, with a Ki67 of around 70% in hotspots. CD5, however, was negative. CD8 was done, which was diffusely positive, and the CD4 was scattered positive. CD56 was diffusely positive, and when we did the LMP1, it was negative. So with this, I mean, it is similar to our previous presenter's case. So we all know the diagnosis, which is extranodal NK T cell lymphoma, nasal type. Although we did not have EBER-ISH to confirm this, but considering the site and the histopathological morphology, along with CD56 positivity and and cytotoxic T cell lineage series 8 positivity, we gave a diagnosis of extranodal NK T cell lymphoma nasal type. So what are the other EBV positive T cell and NK cell proliferations? They can be divided roughly into pediatric population and adult population. So the pediatric EBV positive T cell and NK cell proliferations can further be divided into systemic EBV positive T cell lymphoma and chronic active EBV infections, which include the following these 4 categories. In the adult type, it includes extranodal NK T cell lymphoma nasal type, aggressive NK T cell leukemia, both of which have similar immunophenotyping, and nodal PTCL EBV positive, which comes under the category of nodal PTCL NOS. So the older names given for this was angiocentric T cell lymphoma and lethal midline granuloma. As the name suggests, it is predominantly extranodal lymphoma of NK or T cell lineage, and it is characterized by vascular damage and destruction, prominent necrosis, cytotoxic phenotype, and an association with EBV. It is designated as NK T cell lymphoma because although most cases appear to be a genuine NK cell neoplasm, some cases are of cytotoxic T cell lineage, as seen in our case. And it constitutes to about 5 to 10% of all NHL. It is more commonly seen in Asians and indigenous population of Mexico, Central and South America, and most commonly affects the age group of 44 to 54 years. Male preponderance is present. It is strongly associated with EBV in up to 100% of cases, and EBV when present in the clonal, it is present in the clonal episomal form with type 2 latency. And this commonly shows a deletion in LMP1 gene. Sites of involvement commonly include the upper aerodigestive tract, especially the nasal cavity, and other sites include extranasal NK T cell lymphoma, which is designated as extranasal NK bar T cell lymphoma. These commonly include the skin, soft tissue, GIT, and testis. Some cases may show secondary lymph node involvement. Clinical features mainly include nasal obstruction, epistaxis, and sometimes they present with a destructive mid-facial lesion. Hence, the name lethal midline granuloma was given previously. Skin lesions, when they occur, they present as nodular lesions with ulceration, and intestinal lesion usually lead to perforation or GI bleeding. Lymph node involvement is generally seen in disseminated disease. And marrow and peripheral smear involvement, when present, they overlap with aggressive NK cell leukemia. On microscopy, they generally show extensive ulceration and necrosis, and there is diffuse and permeative infiltrate of lymphomatous cells. There is angiocentric and angiodestructive growth present, which is the characteristic features, with fibrinoid change in blood vessels. There is an intravascular variant in which tumor cells are confined to vascular spaces. The cytological spectrum is broad, and it can vary from small size to medium to large or even anaplastic cells. And they have irregular folded nuclei, which will have granulochromatin, inconspicuous nucleoli, and moderate pale or pale to clear cytoplasm. And mitosis is very easily found. And sometimes they can be associated with florid pseudoepitheliomatous hyperplasia, which may lead to a misdiagnosis of squamous cell carcinoma. So on immunophenotype, they're CD2 positive. Surface CD3 is negative, whereas cytoplasmic CD3 epsilon is positive. CD56 is diffusely positive. CD5 is aberrantly negative. A subset of cases may show CD8 positivity, indicating cytotoxic D cell lineage. And cytotoxic molecules like granzyme B, porphyrin, etc., can be expressed. So EBV expression, the most reliable way to demonstrate is through EBER-ish. LMP1 may be negative in cases with EBV latency type 1, which was probable in our case. The genetic profile are seen are generally recurrent mutations for, which are seen are JAK-STAT pathway, which are mainly due to LMP1 mutation, which is an oncogene, and tumor suppressors like TP53 and RAS. Prognosis-wise, they are very aggressive tumors, but in localized disease, they have a slightly improved median survival. Survival rate has generally been poor earlier, but with recent intensive therapy, including radiotherapy, it has improved. Unfavorable prognostic factors include advanced stage disease, an unfavorable IPI score, invasion of bone or skin, high circulating EBV DNA levels, EBV positive cells in bone marrow, and a high Ki67 index. Extranasal NK T-cell lymphoma are generally more aggressive with a shorter survival and a poor response to therapy. Differential diagnosis mainly include oropharyngeal and sinonasal carcinomas, immune-related vasculitis such as granulomatosis with polyangiitis, and deep fungal infections. Just a word about latent EBV gene expression. What is latency 1, 2, and 3? So the EBV generally, there are two phases of EBV infection, the lytic phase and latent phase. So in the latent phase, it can be divided according to expression pattern of the latency associated proteins, namely LMP and EBNA. So in latency 3, there is unrestricted expression of all the latency associated proteins, and they're highly immunogenic. And prolonged expression is possible only in conditions of impaired T immune surveillance. So mainly they are seen in immunodeficiency associated lymphoproliferative disorders. Latency 2 is limited to EBNA1, EBER, LMP1, LMP2A and 2B. And latency 0 to 1 is mostly restricted, like there's restricted expression of only EBNA1, which is seen in resting B cells. So in Hodgkin's lymphoma, usually they're in latency 2. Hodgkin's extranodal NK T cell are in latency 2. Extranodal NK T cell may sometimes be even found in latency 1. And Burkitt's lymphoma is a classical example of latency 3. So these are my references. Thank you.
Thank you, Varsha. That was a nice case. Questions for Varsha, please. Dr. Asma had the PET-CT findings. What were the PET-CT findings?
It was not available to us, ma'am. We got it for IHC alone.
Oh. And apart from CD56, which other T-cell markers were used?
CD3 was diffusely positive. And CD8 was positive. CD4 was negative in most cells, scattered positive. CD5 was negative.
Okay, these are questions from Dr. Asma to you. Yes. If there are no more questions, then we can. That was a very nice case, Dr. Varsha. So thank you so much. Now we go on to Dr. Kavi Priya from Stanley.
Good afternoon all. This is Dr. Kavi Priya, from Assistant Professor from Stanley Medical College. Am I audible?
Yeah, you are audible. You have to share your screen.
I'm sorry, ma'am.
You have to share your screen.
Okay, ma'am. Okay, ma'am. Is my screen visible?
Yeah, yeah. You are audible. Your
Okay,
screen is visible. You can go.
Okay, ma'am. Okay, ma'am. So I'll proceed with this case. We got a case of a 27-year female with complaints of abdominal pain for the past 1 month. And on examination, the patient presented with right upper quadrant tenderness and no other obstructive symptoms were seen. The biochemical examination and the routine blood investigations were normal. The imaging finding of USG abdomen showed no gallbladder calculi, and but there was increased enhanced echogenicity in the gallbladder. In the contrast, enhanced CT abdomen, there was an irregular mural thickening of the gallbladder wall with an enhanced soft tissue density almost occupying the luminal surface of the gallbladder and also infiltrating into the adjacent hepatic parenchyma. So we received a radical cholecystectomy specimen with a portion of liver and regional lymphadenopathy resection. So the gallbladder that we received was almost about 10 into 7 into 5 centimeter and an attached adherent portion of liver parenchyma measuring about 3 into 2 into 1 centimeter. So on cut surface, we saw a nodular gray-white tumor arising from the fundus and body of the gallbladder and occupying the entirety of the luminal gallbladder surface and also infiltrating, grossly it was infiltrating the adherent liver parenchyma. Coming to the microscopy, we see in scanner view, we're able to see an ulcerated gallbladder mucosa with the muscularis propria showing diffuse sheets and nests of small round blue cells. There were also focal areas of lobular arrangement of tumor cells, and these cells had scant cytoplasm with monomorphic round nucleus and inconspicuous nucleoli with coarse stippled chromatin. So, and there was also lymphovascular invasion present with a lot of tumor necrosis. So with this provisional diagnosis, we proceeded with a panel of IHC markers. So we proceeded with, based on the differentiation of the tumor cell and the morphology, we did chromogranin, which was found to be negative in the tumor cells. Leukocyte common antigen was also negative in the tumor cells. Pan-CK was again negative in the tumor cells. The Ki-67 proliferative index was positive in more than 70% of the tumor cells. Then we added synaptophysin, which came as diffuse cytoplasmic positivity in the tumor cells. So to summarize, we received a gallbladder specimen tumor measuring 9 into 7 into 5.5 centimeter with no calculi. The morphology was small cells with monomorphic nucleus and stippled chromatin arranged predominantly in nests and sheets with necrosis was positive and liver parenchymal infiltration was positive. The nodes, out of the 12 nodes we received, 2 nodes showed metastatic carcinomatous deposits. And in the panel of IHC markers, only the synaptophysin was positive with Ki-67 index showing more than 70% nuclear positivity. So with this, we signed it as neuroendocrine carcinoma of gallbladder, the small cell type, with staging as, pathological staging as T3 and 1. So I'll move to the discussion. Generally, the grading is done based on the mitotic count per 10 hyper field or Ki-67 proliferative index. And here the higher grade is more than 20% of cells in both mitotic count and Ki-67. This is the evolution of gallbladder. This is the evolution of neuroendocrine neoplasms in the gastrointestinal system. So from 1980 to WHO 2010, but there has been a modification in 2017. I'll just explain the modification alone. In 2010, there was a well-differentiated neuroendocrine grade 1 and grade 2 based on the mitosis and Ki-67 index. And then the higher grade was classified as poorly differentiated neuroendocrine neoplasm or carcinoma of grade 3. In 2017, the modification is that in well-differentiated subtype itself, you had an additional neuroendocrine grade 3. That is, the differentiation was quite well, but the mitosis and proliferative index were high. So those were classified under the well-differentiated type itself. When the cells were showing poor differentiated, they were automatically classified as neuroendocrine carcinoma, either of small cell or large cell type. So coming to the incidence of gallbladder neuroendocrine tumors, they usually comprise of 0.5% of all the neuroendocrine tumors and about 2.1% of gallbladder tumors. According to the US-based population seed registry data, only 278 cases have been reported from a period of 1973 to 2005. And in India, from various literatures, I was able to pick out about 67 cases. And in our institute, this was the first case reported in gallbladder neuroendocrine tumor, that is. So if you see clinically, most of the carcinoid tumors, they usually present with carcinoid syndrome, that is flushing, diarrhea, or any peripheral edema. But most of the gallbladder neuroendocrine tumors or extrahepatic bile duct tumors are non-secretory tumors. So clinically, they're not going to have any symptoms. And if you see the incidence, it's more common in women with average age of presentation between 35 to 80 years. These are cases from different studies. I just wanted to outline that the clinical presentation is predominantly just pain or the weight loss, with only one case showing Cushing syndrome. And if you see that tumor size as small as 2.5 centimeter also presented with regional metastasis to lymph nodes or liver metastasis. So most of the tumors presented with metastasis with very indolent clinical presentation. So treatment for early stage tumors are usually simple cholecystectomy with radical cholecystectomy and post-surgical chemotherapy usually occupied only for very aggressive tumors. So if you see the prognosis, it's generally poor compared to the other gallbladder adenocarcinoma, and the 1-year survival rate is 43 to 45%, and 4-year survival rate is only 22 to 26%. So to summarize, gallbladder neuroendocrine carcinoma is generally very aggressive with early invasiveness, and the cutoff for the tumor size is basically 2.5 centimeter in size. And radiological imaging and tumor biomarkers are not helpful in differentiating the gallbladder tumors, neuroendocrine tumors. So generally the histopathology is the gold standard for diagnosis. And regarding the treatment protocol and prognosis of gallbladder neuroendocrine carcinomas are usually limited due to the rarity of the tumors. Thank you. I would like to thank Professor Dr. Arnalata ma'am, Professor Dr. Valanmati ma'am, and Professor Dr. Gomati ma'am for giving me this case to present this forum. Any questions, ma'am?
Kavita Priya, right?
Yes, ma'am. Yes, ma'am.
What is the cell of origin, ma'am?
Ma'am, actually, there are three hypotheses for this. It could be either from an undifferentiated stem cells of in the gallbladder itself, or it could be due to any kind of chronic inflammation. There might be an intestinal metaplasia or gastric metaplasia, which can be converted into neuroendocrine carcinoma, or prolonged or long-standing adenocarcinoma can be converted into neuroendocrine carcinoma. But in the third case, it would be presenting as a mixed adeno and neuroendocrine carcinoma.
Did you find any metaplastic changes in the epithelium in this gallbladder?
No, ma'am. We didn't find any metaplastic change, and there was no calculi also in our case. So,
okay, then in that case, there was no adenocarcinoma also, right?
No, ma'am. There was no adenocarcinoma.
How do you hypothesize that this carcinoid, this neuroendocrine tumor had arisen?
It could be from. That's all, ma'am. Out of the three hypotheses, we are guessing it could be from the first hypothesis, that is that from the undifferentiated stem cells of the gallbladder epithelium.
Okay, thank you.
Thank you, ma'am.
Thank you, Dr. Kaitya. It was really wonderful. Presentation was good. Then we go to the last
Yes, yeah, the final presentation of today is Dr. Krishna Kumar, ma'am. Krishna Kumar, sir, you can start, sir. Welcome, sir.
Yes, madam. How scary with a lot of cancers and other things. Why I'm not able to scare the thing, ma'am? Are you able to see?
Yes, sir. Yeah, you are. You are.
You're able to see the slides.
You are audible. You're not able to see your slides.
Not able to see the slides. Hold on.
Last time also it happened, KK.
Yes, madam. Yes.
Why?
I know, ma'am. I know something is happening. Yes, you're able to see the slides, ma'am?
Yeah.
Yes, yes, sir.
Okay. See, this is all. Let's see.
Go to slideshow mode and start.
Yes, madam. Yes. Okay.
No.
You are able to see?
Now it is. Yes.
Okay. See, this is corneal button. Patient has got a severe corneal acute suppurative inflammation. So it is an infective keratitis, and the corneal buttons come to us. And we know it is an infective. We do the special stains, and in GMS we see the filaments. The dilemma is how to, is it a fungus or what type of fungus it is? They want to know whether it is fusarium or really I had a dilemma to tell what type of fungus it is, and I told them I really don't know. GMS it is positive, but surprisingly PA stain it did not stain well. So I said, please correlate with microbiology department, and these folks were able to culture it, and then they said this is Pythium insidiosum keratitis. And I understand that the patient had evisceration done. The entire intraocular contents was removed because of the severe intraocular inflammation. So we see this quite often in ophthalmic practice, where we see infection treated as fungal keratitis because filaments are seen, and then it does not respond to the antifungal agents, and it comes to us. And then now, because of our experience looking at morphology, we tell could be Pythium. Then the microbiology does a PCR and they tell it is Pythium. So this Pythium insidiosum is something belongs to an oomycete, and it is seen more in dry conditions. And there are two forms. We see more of the hyphal form here, and it can come in the subcutaneous, vascular, ocular, and systemic. So I have been seeing mostly in the corneal specimens, and sometimes we see endophthalmitis and all those things. And these patients really don't do well unless until it is diagnosed early and the corneal tissue is removed as a part of a therapeutic parentetic keratoplasty and corneal transplant is done. My only question is, I want to know, like, are you compelled to make a diagnosis based on GMS staining, what type of fungus it is, when the sample does not go to microbiology? And what is your thought process on Pythium infection in other organs like blood and tissues? The second, so this is Pythium insidiosum keratitis. Sweta Agarwal is a corneal surgeon and Lily Teresa is a microbiologist. So this was published in British Journal of Ophthalmology, and we see these cases quite in Tamil Nadu and also in dry places like North India. And second thing is orbital abscess. We know this is fungus, but the dilemma is the surgeon has not sent the sample to microbiology department thinking it is tuberculosis something, and so we'll see necrotic granuloma with the fungal filaments. They ask, can you tell the fungus? So morphologically, can we tell the fungus? So if we tell yes, fungus, this we see the filaments, we see some branching, we see septae. So I commit as aspergillosis. But what the dilemma is, this is invasive aspergillosis. The sample has gone to Apollo also and also into our microbiology department, and we're waiting for the report. I was reading some articles. What they tell is there is difficulty or challenges in morphologically, the pathologist looking at GMS stain and telling the subtyping of fungus. So I thought, let me share some of these slides. The first case slide is, it was histopathologically diagnosed as aspergillosis. You see this septate and branching. GMS stain also, they made a diagnosis of aspergillosis, but culture, it was reported as rhizopus. This is American Journal of Clinical Pathology, 2009. The second case, histopathology diagnosed as mucormycosis. GMS stain, they made a diagnosis of mucormycosis, but culture, it was aspergillosis. third histopathology, it was aspergillosis, but culture and it was diagnosis Fusarium. So the dilemma is, are we justified in making morphologically looking at section? Are we justified in making a diagnosis of fungal subtype? That's something because they need to start on amphotericin B and expensive antifungal agents. So sometimes we do PCR sequencing, but the PCR sequencing has got its own issues of the contaminant and all those things. So this is something I face in my ophthalmic practice periodically, where we have to commit something on the fungal type, and it is really challenging. I thought, let me share this with you all. The next is alopecia. We get a scarring alopecia and sections come. We see a lot of inflammatory cells, lymphocytes around the follicular epithelium. So there is only two diagnoses in these cases, whether it is discoid lupus erythematosus or lichen planopilaris. And here you find the sweat glands are there. This is horizontal section. You find sweat glands are there, and but you are not able to see any sebaceous glands. And here you find still the dense infiltrate. The infiltrate is more around the vascular cells. Usually when I see reports, cases like this, I use the term autoimmune alopecia with scarring, because sometimes it is very difficult for me on horizontal section to tell whether it is a DLD or a lichen planopilaris. I just take vertical sections, and if I'm able to see the thickened basement membrane, I give a comment as DLE. Or I am not aware of anybody CD123. The article still that CD123 is a good marker to differentiate DLE in scarring alopecia. I have never used CD123. So usually I resort to vertical sections or ask the dermatologist, are there any other lesions elsewhere? So based on the clinical thing, we make a diagnosis of discoid lupus erythematosus with scarring alopecia. The next thing is sometimes we also get like this. You get a scarring, broken hairs, alopecia. You know, this is, you see this pigment cast here, and sebaceous glands are intact. We know this is a trichotillomania. So we also get easy things like this. Then this sort of children are referred to for counseling. Thanks a lot. I thought, let me share these simple things with you. And any thought process whether subtyping of the fungus based on paraffin sections.
Krishna Kumar.
Yes, ma'am.
For cases, did you correlate with the microbiology department, or was it?
No. The first case, microbiology gave us pythium. The second case is aspergillosis, and we are waiting for the report. Because initial biopsy was aspergillosis by microbiology and myself. The patient has undergone excenteration. Excenteration means they remove the eye and part of the orbit.
I know.
So the sample is also going to upload for Ram Gopal to see. I'm waiting for the upload report also, madam.
Okay. My other question is there any difference in the treatment modality of the various fungal, or they use a...
No, madam. I think in some cases they want to use voriconazole or in amphotericin B something. So they're very particular. Ram Gopal is very particular. Tell me whether it's mucormycosis or not, or aspergillosis or fusarium. I find it very difficult sometimes after reading.
No, between mucor and aspergillosis, it is always a problem. But at least if you have any vascular invasion, then you can be a little bit sure that it is probably a mucor.
No, madam, there is a lot of, there's a recent article, there's a group of fungus, angioinvasive fungus. Even aspergillosis has got vascular invasion. So this is really sometimes I find it difficult.
I know.
What about pythium, madam? Because we see this in cornea, like any experienced people have got pythium infection in other organs, infections and inflammation, madam.
I don't know. I'm not competent enough to comment on this.
Okay, madam. So this finishes my case, madam.
Thank you.
Thank you, ma'am. Thank you. Thank you, Dr. Thank you, Dr. Pathologist.
Thank you, sir. Thank you for the nice cases from skin and ophthalm you share with us. And any questions for Krishna Kumar, sir?
Okay, ma'am.
Ma'am, there are no questions. So we come to the end of our 24th City Pathology meet. Ma'am.
Dr. Valan, if you have the certificates, you can project it now. Otherwise,
Ma'am, as we did it in the previous meet, we'll share it with them. We'll send with the persons through mail, ma'am.
Okay. Then we will end up the session. Thanks everyone for joining us. The recording will be available in the YouTube channel, and if those who have missed can watch it in the YouTube channel also.
Okay, Valar, congratulations. You're approaching Silver Jubilee celebration of your city.
Next will be Silver Jubilee.
So I hope that will be at least, like a person to person. I hope it is not a Zoom. If it is, we are able to gather in some place, that will be really nice after a long time, right?
People are happy with this online thing, man. Many are able to see.
Pardon?
So we'll take the suggestion.
Everybody are happy with the virtual platform now because they are able to make it, they are able to see it. But once in a while, we should have physical also.
Yeah, I know. That is true. Anyway, congratulations for the forthcoming meeting.
Yes, ma'am. So we'll look forward to more suggestions and ideas, ma'am. So for the 25th date, yes, ma'am. So thank you all for the active participation and very impressive presentations, ma'am. The quality of cases have definitely improved, and thank you so much. And we'll see in the maybe in April, ma'am, for our next city pathology meet, the 25th meet. We'll take the suggestions and we'll go forward, ma'am. Thank you, ma'am. Thank you, Padmadi, ma'am, and thank you all the presenters.
Thank you, ma'am. Thank you, Vanan.
Thank you, ma'am.
Thank you.
Can we end up the meeting?
Yes, ma'am.
Thank you.